This is part 7. We're on slide 11 of lecture 15, chapter 20, resistance, and that begins in the textbook on page 517. We looked last time in part 6 at the mechanisms by which bacteria can resist the action of antimicrobial drugs, and we looked at the underlying things that can lead to that, or lead to that ability to be resistant. And now we're going to look at some examples of emerging resistance, and that means emerging, i.e. coming forward. Emerging resistance, these are bacteria that are becoming a problem. Enterococci, Enterobacteriaceae, Mycobacterium tuberculosis, Neisseria gonorrhea, Staphylococcus aureus. So on slide 12 we have our enterococci. So entero meaning inside, in this case relating to the intestines, cocci relating to the shape of the cells. So these are cocci-shaped cells that are in our intestines, and they are typically part of our normal microbiota. But when they go bad, they can lead to infections, and they are the cause of many healthcare associated infections, HAIs. So a couple of reasons why enterococci are a problem. They have some intrinsic resistance to our antimicrobials. First of all, they're penicillin binding proteins, PBPs. You can also remember those as peptidoglycan building proteins. They have low affinity for beta-lactam antibiotics. So what does the low affinity PBP mean? It means that the PBP doesn't like to have the beta-lactam antibiotic stick to it. The shape of the active site of the PBP isn't a very good fit to the shape of the beta-lactam antibiotic. So the PBP will bind to its regular substrate and it'll go ahead and build those cell walls, but it doesn't like to have the beta-lactam antibiotic stick. And because of that, when we then apply beta-lactam antibiotics to these bacteria, the beta-lactams don't then interfere in any significant way with the ability of the PBPs to build cell walls. The other reason that many enterococci are problematic is that they have R plasmids. And R plasmids are those little pieces of DNA inside our bacteria. Here's the regular circular chromosome, and then in addition to that they have another piece of DNA, again in a circle, called a plasmid, and two bacteria can get together. They can form a junction called a sex pilus. They can put their plasmid through replication, they'll replicate it, and they can give the plasmid away to the neighbour, and all of the genes that are on this plasmid, some of those genes important then in the ability of the microbe to be resistant, they are now given to this bacteria, and this is horizontal gene transfer. So VREs is a bacteria or a bacteriotype that you might have heard about, vancomycin resistant enterococci. This is on an R plasmid, this resistance, and plasmid is transferable to other microbes, so not just between microbes of the same species. When we think of, say, sexual reproduction, it's always a human having a human baby, or it's a plant having an oak tree, having a human having an oak tree baby. In this case, the ability of the bacteria to pass its plasmid to other bacteria is well beyond just the species. We looked at vancomycin last time. Vancomycin is one of those last resort antimicrobials. Vancomycin is one of those drugs that blocks the building of bacterial cell walls. It blocks the construction of peptidoglycan, but it is not a beta-lactam antibiotic. On slide 13, I have that same picture from our vancomycin, the building of our peptidoglycan, our sugar layers, our peptide side chains, and one final piece of the puzzle is to stick these side chains together, and that links the layers of peptidoglycan. And what does this last step of linking is an enzyme. Let's join up our peptidoglycan here. But in order to get in there and do that last linking up, the enzyme has to actually fit into the space. And that's how our vancomycin works. Our vancomycin sticks to the end of these chains. And then when the enzyme comes in and it tries to fit into the gap to do its work, the enzyme is blocked. It literally can't fit in. But that requires the vancomycin to stick to the chain. And you'll see that on the top picture there, we have a red circle, a blue circle, a green circle, and two red circles. And it's these two red circles at the end that are important, because these fit the vancomycin drug. So our vancomycin can clamp onto. But a change in the order of the peptide side chain, go from being a circle to a square, and now our vancomycin can't clamp on. It's not the right shape anymore. Yet our enzyme that builds the bond, that enzyme can come in and it can build that bond together. So a change in the amino acid in that side chain, in that amino acid peptide side chain, leads to vancomycin resistance. Number 14, slide 14, Enterobacteriaceae. These are gram-negative bacteria. They're present, again, the entero part. They are present in our digestive tract, and they are typically normal members of the microbiota in many cases. E. coli, for example, is an Enterobacteriaceae. All of the Enterobacteriaceae are gram-negative, and because they're gram-negative, again, they have these intrinsic abilities to withstand antibiotics, and they have the outer membrane that is an additional barrier. Other ones you may have heard of: Salmonella, Shigella, Yersinia pestis. That's the bacteria that causes the Black Death or plague. In addition to that outer membrane, of them being gram-negatives, they have also developed beta-lactamases, and some have developed extended spectrum beta-lactamases. So beta-lactamases are those enzymes that snip up beta-lactam drugs before they can begin to inhibit the penicillin binding proteins. Carbapenems, those were a type of beta-lactam antibiotic. Another one of those kind of last resort drugs used to treat high-risk bacterial infections, used to treat drug-resistant or multi-drug resistant bacterial infections. So you would go in, you would try the regular drugs. If those wouldn't work, your bacteria was resistant, then you would start trying other drugs. And one of those drugs you would use as a last resort was carbapenems, because they were good at inhibiting beta-lactamase enzymes. So if you had a bacteria that had an extended spectrum beta-lactamase, there's a good chance that carbapenems would be able to work. But we are now seeing carbapenem resistant Enterobacteriaceae that are, again, the bacteria are going to be able to resist them, again, through, in most cases, the activity of their beta-lactamases. So CREs, carbapenem resistant Enterobacteriaceae, are often treated, well, sometimes treated with this drug colistin. It's a medication that's usually considered too toxic. So as you kind of move up the chain of drugs that you might try, a few reasons why they're held back. Number one, they're held back because we don't want to allow the bacteria too much contact to become resistant. And secondly, they're held back because they may be toxic to the patient. And colistin is one of these examples where if the carbapenems have failed, there's really no other choice. It's either try and kill the bacteria that harm the patient, or don't kill the bacteria. There's even now ideas of plasmids encoding resistance to colistin. Colistin acts as a detergent on cell membranes. So the reason why it has such a low therapeutic index is because the cytoplasmic membrane of a bacteria and your cytoplasmic membrane are very, very similar, so that if colistin is going to harm the microbes' cell membrane, it's also going to harm your cell membrane. Okay, on to slide 16, Mycobacterium tuberculosis. We've looked at tuberculosis, Mycobacterium tuberculosis before. Two reasons why it has intrinsic resistance: its waxy cell wall and its slow growth. Slow growth then relates to the ability of many antibiotics to affect it, because many antibiotics are disrupting. They're disrupting, say, the building of cell walls. They're not able to harm a bacteria once the cell wall has been built. When we're dealing with a Mycobacterium tuberculosis infection, we're often dealing with very large numbers of bacteria. And with those very large numbers, we have the ability of the population to mutate and gain further resistance. So one way to counteract that ability to mutate in these very large populations of Mycobacterium is to use combination therapy. So we have various different versions of Mycobacterium tuberculosis in very large numbers. And some of those bacteria are resistant against some drugs, and some of those bacteria are resistant against other drugs, and some bacteria are more susceptible. So if we apply our first medication and we kill some of the bacteria, there's still plenty left to go on and become resistant. If we apply a second drug, we can kill more. If we apply a third drug, we can kill more, until we have killed enough of the bacteria so that they can't continue to become resistant. It's a very long treatment though, 6 months or more of treatment. And one problem is that patients don't comply. On to slide 17. There's various different levels of Mycobacterium in terms of their resistance. There's multi-drug resistant M. tuberculosis, or MDR-TB. It's resistant to those first-line antibiotics, isoniazid, I can never pronounce those names, and rifampin. Rifampin is that one that inhibits the RNA polymerase. Isoniazid is the one that interferes with the production of the mycolic acid. That's the unusual component of the Mycobacterium cell wall. And then there's extensively drug-resistant M. tuberculosis, XDR-TB, a great concern because it is resistant to even more drugs, including what we call second-line antibiotics. So one way that you can get around the problem of treating tuberculosis, the big problem is very long treatment, is directly observed therapy can prevent emergence. We'll talk about this in a second. But when you take an antibiotic, well, let's talk about it actually in slide 18, antibiotic treatment. You go to the doctor, you have a bacterial infection, the doctor says take 1 pill per day for 10 days, or maybe 1 in the morning, 1 at night for 10 days, and then you start to take the antibiotic, and in the first few days you are feeling better, and you think, why should I continue to take the rest of these drugs? I'm over the infection. But the problem is, as time goes on, we have a number of microbes, we have their resistance, so some microbes have a low resistance to our drugs. Some microbes have a high resistance to our drugs. Most of the microbes are somewhere in the middle, because there's a large population and there's variation in that population. On the first few days of our antibiotic treatment, we are killing all the easy to kill bacteria. And as we continue working day after day, taking our drugs, we are beginning to kill the medium ones, and we are getting to killing the high ones. If we just stop taking our medication when we start to feel better, we're feeling better because we've killed most of the bacteria, but we've left behind the bacteria that are the hardest to kill. And these are the ones we don't want to leave behind, because we leave them behind and they just regrow. And now our population is harder to kill than it was before. So one reason why we want to make sure that we keep taking all of our antibiotic medication is so that we get to kill all the bacteria, not just the ones that are easy to kill. The second thing is that as we progress through time and we have the drug level in your body, you take your first pill and then you take your next pill and then you take your next pill to try and maintain that killing level. And the reason why the doctor says try not to miss any doses is because you take your first pill, you take your second pill, and then you forget your third pill. And then you are no longer maintaining the drug at its treatment dose. And once again, you're only killing the easy bacteria. This is the dose required to kill all the bacteria. At this dose, we're only killing the easy to kill bacteria. So we want to not skip doses so that we maintain the level of drug in our bodies at the killing level, and we don't want to stop too early because we don't want to leave those tough bacteria inside us to just regrow and kind of come back stronger. In one study of children with streptococcal infections, they got a 10-day course of penicillin. More than half of the patients had stopped taking their medications by the third day. By the 9th day, 82% had stopped. So back to slide 17 and tuberculosis. We want to make sure that these patients are taking their drugs regularly for a very long period of time. Directly observed therapy means that a healthcare worker or a nurse physically turns up to the patient's home, gives them the pill, and watches them take the medication. And they do that day after day after day, so that the patient is reminded that they need to take it and be motivated to continue taking that medication. On to slide 19. Neisseria gonorrhea. This was once a bacteria that was very susceptible to penicillin. In fact, when penicillin was first introduced to the market, part of the, if you look at those old advertisements, it was advertised as being able to treat gonorrhea in 24 hours. But through acquisition of a mutation and acquisition of plasmids, in this case a plasmid that encodes penicillinase. Penicillinase is a beta-lactamase that specifically snips up penicillin. So the gene for the beta-lactamase. So beta-lactamase is an enzyme. Enzymes are proteins. Proteins are encoded in genes, and our plasmid has genes. And those genes on the plasmid are transcribed and translated just like the genes on the bacteria's regular chromosome. So transcription and translation of this gene builds a protein, and in this case, this gene on this plasmid is able to build a beta-lactamase that can roam around the cell and snip up, in this case, penicillin. In particular, it is a penicillinase. For Neisseria gonorrhea, combination therapy is again typically indicated. Ceftriaxone, which is a cephalosporin, a beta-lactam antibiotic, in conjunction with azithromycin, which is a macrolide. Macrolides are those drugs that interfere with protein synthesis. Macrolides are those ones that stick to the 50S subunit of the ribosome, and they interfere with the ribosome's ability to stick amino acids together. Slide 20, Staph aureus, becoming an increasing problem. You may have all probably heard of MRSA or MRSA, methicillin-resistant Staph aureus. Now, one thing about Staph aureus is that most of us have Staph aureus on our skin, and we are asymptomatic on our skin and in our nasal lining. About 30% of healthy people have it. It's a very common healthcare associated infection. Most strains of S. aureus have penicillinases. With the introduction of low affinity PBPs, means now that we are seeing Staph aureus that is increasingly resistant to all beta-lactam antibiotics and methicillin, which is a type of penicillin that was altered to become resistant to beta-lactamases. So when we use the term methicillin-resistant Staph aureus, actually resistant to a whole number of other drugs. I guess we are talking about the toughest of the drugs that it can defeat. So methicillin, it's a narrow spectrum beta-lactam antibiotic. It is naturally penicillinase resistant, but now MRSA is reported in more than 50% of hospital S. aureus infections. So if you go into the hospital with S. aureus, it's likely that it is MRSA, MRSA. More MRSA is seen in the intensive care unit than the non-ICU. MRSA is resistant due to its broad-based beta-lactam resistance through these low affinity penicillin binding proteins. It's also resistant to cephalosporins. Those are beta-lactam drugs. It's resistant to aminoglycosides. Those are drugs that bind to the 30S subunit of ribosomes. It is resistant to fluoroquinolones. Those are the ones that interfere with DNA winding and unwinding. It's also resistant to macrolides, those ones that bind to the 50S subunit. So MRSA is multi-drug resistant, and it's been typically treated with vancomycin. But we are currently seeing Staph aureus becoming resistant to vancomycin, and now instead of MRSA, we have VRSA. So on to slide 22. We've looked at the mechanisms that these different bacteria have to resist drugs. Some of them have low affinity PBPs. Some of them gain their resistance via R plasmids. Some are gram-negative, and that makes them more resistant. Some have beta-lactamases. Some have extended spectrum beta-lactamases. We looked at the idea of the importance of taking antibiotics, following the instructions, taking the full course. We looked at the idea of combination therapy in treating tuberculosis and gonorrhea, in that we don't want to leave any microbes left over to then recolonize, repopulate, and kind of grow back stronger. So for Enterococci, Enterobacteriaceae, Mycobacterium tuberculosis, Neisseria gonorrhea, and Staph aureus, be able to recognize them, recognize what their mechanism for resistance is, know some important examples of resistant types of bacteria in those categories. For Enterobacteriaceae, know what we might treat CREs with and why that colistin drug is toxic. For Mycobacterium tuberculosis, understand what direct observation is. For Staph aureus, question you might want to ask yourselves: why do you think VRSA is reported in hospitals and mostly confined to hospitals? The answer being that hospitals are where the people with the bugs turn up, and hospitals are also a kind of a hotbed of antibiotic use. So combine lots of sick people with lots of antibiotics, and those are the circumstances by which bacteria can become resistant. Bacteria can get together and they can shoot each other their plasmids. Bacteria in large numbers can undergo mutations, and then the variation is selected for in terms of those bacteria that are best able to resist the drug.